Welcome to today's session on fluid and water balance. This is part of our fluid and electrolyte series in PHRD 515, renal disorders. I'm Dr. Jeffrey Gonzalez. This is a pre-recorded lecture that will complement the in-class lectures on fluids and electrolytes. By the end of this presentation, you should be able to describe how tonicity and osmolality are maintained in the extracellular fluid, understand the different body fluid compartments, and explain the distribution of water in the body. We'll also explore the role of sodium, differentiate between osmolality and tonicity, and discuss how fluid administration affects body compartments. Finally, we'll cover fluid therapy types and recognize signs of fluid imbalance. Our primary reference is a chapter on sodium and water homeostasis from DePiro Pharmacotherapy. This reading provides a strong foundation for understanding the physiologic and pharmacologic principles we'll discuss. We'll begin with an overview of body fluid compartments, how fluids are distributed and move within the body, and then how water balance is maintained. Daily fluid intake comes from drinking water or volume or fluid, food, eating food, and metabolic oxidation. This totals around 2.4 to 3.2 liters in an adult. You can see the breakdown between drinking fluids, eating food, and oxidative processes here. Output occurs through urine, stool, skin, and lungs, and generally matches intake in a normal, healthy adult. This balance is crucial for homeostasis, and the body always wants to maintain this balance. Any alterations of this balance may affect the volume status of the patient and, most importantly for electrolytes, sodium. Total body water includes all fluid compartments and varies by weight, sex, age, and disease. In general, total body water is about 60% of lean body weight in males and 50% in females. This averages about 42 liters in adults. In healthy adults, water makes up approximately 60% of our total body water. Because such a large portion of the body is water, maintaining appropriate fluid balance is critical to healthy body function. Water in the body is distributed between two compartments, the intracellular compartment and the extracellular compartment. The extracellular compartment is further divided into two spaces, the interstitial space and the intravascular space. Fluid or water in the intracellular space is called intracellular fluid, and fluid or water in the extracellular space is called extracellular fluid. Water movement between the intracellular fluid and the extracellular fluid is maintained by cell wall, which function as a semipermeable membrane. Through active and passive transport, electrolytes and water move between the intracellular and extracellular spaces. Every cell membrane is completely permeable to water, so that water moves freely between the three compartments. In contrast, a cell membrane is not permeable to all electrolytes and molecules. Some electrolytes move across the cell membrane through passive diffusion, and others through active transport. The main way that sodium gets across the cell membrane is through active transport via the sodium-potassium ATPase pump. Electrolytes have an osmotic potential, which refers to the affinity of electrolyte for water. Electrolytes with the high osmotic potential are the main driving force that moves water between compartments. The phrase water follows solute means that certain electrolytes move water between compartments as they themselves move. Sodium and dextrose have a high osmotic potential, and movement of these solutes in and out of cells and between extracellular compartments can result in major fluid shifts between those spaces. Electrolytes and non-electrolytes are dissolved in total body water, as you can see here on the diagram. They are called solutes. Electrolytes include both cations and anions and are listed here. The cations are sodium, potassium, calcium, magnesium, and hydrogen. Anions are chloride, bicarbonate, and phosphate. Non-electrolytes include urea, proteins, coagulation factors, bilirubin, and glucose. As you can see in this diagram, total body water, like previously described, is divided between the intracellular fluid and the extracellular fluid. The intracellular fluid is about 2/3 of total body water, while extracellular fluid is 1/3. Within extracellular fluid, 75% of fluid is in the interstitial space or interstitial fluid. The remainder, 25%, is intravascular fluid in our bloodstream. Two-thirds of water in our body is found inside our cells. There are many electrolytes and other charged molecules inside our cells, the major ones being potassium and its accompanying anions. There's no way to directly measure or clinically assess the amount of water inside our cells at any given time. Clinically, we can only assess the amount of water in the extracellular compartments. Therefore, when we talk about the evaluation of volume status in a patient, we're referring to the volume in the extracellular space. The remaining 1/3 of our total body water is in the extracellular compartment. As mentioned, this is divided into two spaces, the interstitial space and the intravascular space. The interstitial space is a tissue surrounding our blood vessels, and the intravascular space is our blood vessels. Remember that our blood vessels contain various blood cells that are suspended in liquid called plasma. So when we talk about fluid in the blood vessels, we're also talking about the plasma. Within the extracellular compartment, most of the water will be in the interstitial space compared to the intravascular space. Also, within extracellular compartment, the electrolyte concentration is fairly similar between these two spaces. Sodium is the main electrolyte in the extracellular fluid, and given its high osmotic potential, is the main electrolyte that moves water. The one difference between the interstitial and the intravascular spaces is the large amount of proteins found in the plasma. Proteins, mainly albumin in the plasma, exert an osmotic pressure that prevents fluid from leaving the intravascular space and exerts a pull from the interstitial space. This is referred to as colloid osmotic pressure. Simultaneously, the volume of blood exerts a pressure within the blood vessel to exceed pressure in the interstitial space. Hydrostatic pressure is a pushing force that is exerted on the blood vessel wall, which causes water and electrolytes to move through the blood vessel wall into the interstitial space. Colloid osmotic pressure and hydrostatic pressure represents the pull and push required to maintain balance between the interstitial space and intravascular space. Clinically, we can assess how much fluid is in these spaces, and we talk about a patient's volume status. We are referring to the extracellular fluid. Here's a visual that summarizes the division of total body water into intercellular fluid and the extracellular fluid. Further into the interstitial and intravascular compartments. Let's go through an example of total body water. We know that total body water is 60% of a person's total body weight. For a 70-kilo person, their total body water would be 42 kilos, 0.6 times 70. Since kilogram is not a normal measurement of volume, we change it to liters. 1 kilogram of water equals 1 liter of water. Therefore, the 70-kilo person has a 42 liters of total body water. When we talk about total body weight to use in this equation, you always want to convert pounds to kilograms. Remember that 2.2 pounds equals 1 kilogram. Of that 42 liters, 2/3 is found in the intercellular compartment, which would be about 28 liters. The remaining 1/3, or 14 liters, is found in the extracellular compartment. If we further divide the extracellular compartment into the two spaces, we would say that about 3.5 liters of water is in the intravascular space, and about 10.5 liters of water is in the interstitial space. So only 3 liters of a 70-kilo person's water is in their intravascular space. This is important to consider when thinking about volume status. Our intravascular space contains such a small amount of our total body water that any changes to it will have a much bigger impact in the other spaces. Water moves freely across cell membranes driven by osmotic gradients. This movement is essential for maintaining equilibrium between the compartments. Water balance between the various spaces is achieved through osmolality. Osmolality is the concentration of solutes measured in millimoles per liter of a solution, in this case, water. Although the solute compositions of each of the 3 body water compartments is different, only plasma solutes can be measured by the way of a venipuncture. Dissolved in total body water are several types of solutes, both electrolytes and non-electrolytes. The sum of all the amount of these solutes divided by the volume of plasma determines a patient's plasma osmolality. Tonicity refers to the fluid tension within the extracellular fluid or the intercellular fluid and describes the relationship between the total solutes and water within these compartments. The main reason water moves between the extracellular fluid and intercellular fluid is because the solutes move between these compartments. Essentially, water moves when the concentration in each compartment changes. The extracellular fluid concentration of effective osmoles, mainly sodium, determines its tonicity, which directly affects the distribution of water between extracellular fluid and intercellular fluid. In extracellular fluid, sodium, chloride, proteins, glucose, and medications contribute to osmolality. In the intracellular fluid, potassium and proteins are the key solutes. Each fluid space has its own osmolality. However, only the space that we can directly measure is the intravascular space. So mostly we'll be talking about plasma, aka serum, osmolality. When water and solutes are balanced, normal plasma osmolality is about 280 to 290 millimole per liter. We can measure the plasma osmolality via a blood sample, which accounts for all of the solutes shown here in the diagram. We can also estimate plasma osmolality by measuring only the most prevalent particles in the plasma, sodium, urea or BUN, and glucose. The equation shown is how you would take the serum values and estimate plasma osmolality. If you look at the equation, you can see that the serum sodium contributes the most to osmolality, meaning it's the most effective solute at moving water between the three compartments. This is a hint that explains why disorders of water and sodium are closely connected. The amount of fluid in each compartment is dependent on osmotic pressure and hydrostatic pressure, as mentioned before. The distribution of water among the three body water compartments, intracellular, intravascular, and interstitial compartments, is dependent on these pressures. Hydrostatic pressure is a pressure exerted by water. Osmotic pressure is a pressure exerted by the solute. Water will always move from an area of low solute concentration to high solute concentration. Hydrostatic pressure pushes fluid out of the capillaries, while osmotic pressure pulls fluid into the capillaries. Albumin plays a major role in plasma osmotic pressure. Because water can move freely between the three compartments, the osmolality of all three compartments is always the same under normal conditions. If a solute is added to one compartment, which would therefore change its osmolality, water moves into that compartment until the osmolality of all three are equal again. Likewise, if water is added to the compartment, which would change osmolality, the water would flow out of that compartment to restore equality between the three compartments. It is easiest to add solute and water to the intravascular compartment. Think of intravenous fluids. And is usually the compartment we're talking about when considering these changes. The movement of water between the compartments due to changes in plasma osmolality is an important concept in understanding the clinical consequences of sodium disorders. Intravenous fluids are commonly used in hospitalized patients and can cause and be the cause of or treatment for sodium disorders. If enough intravenous fluid is given, think many liters, it can lead to changes in plasma osmolality and trigger water movement, as discussed previously. In this course, we will mostly be talking about using intravenous fluids to treat electrolyte and volume disorders. There are four main types of intravenous fluids commonly used in medicine. The distribution of IV fluid is dependent on two things: the ability of the solute in the fluid to cross body water compartments and the osmolality of the fluid relative to the plasma osmolality. The solute contained in the intravenous fluid determines where the fluid distributes in the body. Dextrose solutions distribute across all three water compartments because both water and dextrose, aka glucose, are permeable to the cell membrane. Saline solutions distribute in the extracellular compartments because the cell membrane is not permeable to sodium, but the capillary wall between the interstitial space and the intravascular compartment is. Remember that sodium enters a cell through the active transport mechanism sodium-potassium ATPase pump. Lactated ringers distribute in the extracellular compartments because of the cell wall is not permeable to electrolytes in the solution. Plasma expanders remain in the intravascular compartment. Plasma expanders could be fluids such as albumin, packed red blood cells, and won't be covered in this lecture. Intravenous fluids are categorized relative to plasma osmolality. Isotonic fluids have osmolality similar to plasma. Hypotonic fluids have an osmolality less than plasma. And then hypertonic fluid has an osmolality greater than plasma. IV fluids are categorized into crystalloid and colloids as well. Crystalloid solutions contain small molecules and distribute across the compartments, while colloids contain much larger molecules that remain intravascular and may generate an oncotic pressure in the intravascular space. There examples of crystalloid solutions are normal saline, lactated ringers, Plasma-Lyte, and dextrose. Examples of colloids are albumin, dextran, and packed red blood cells. IV fluids are commonly used in hospitalized patients. The type, amount, and rate depend on the condition being treated. Though infused into the intravascular space, fluids distribute based on their composition. Thus, any infused intravenous fluid into the blood, but then follow patterns of fluid distribution based on the tonicity and osmolality of that solution. Dextrose, which is a sugar, is a bit different than electrolytes like sodium. Dextrose 5% in water is isotonic in the bag, but becomes hypotonic once metabolized. It distributes freely across membranes. It is not suitable for resuscitation because it does not stay in the intravascular space. But it is useful for maintenance fluid or maintenance therapy. So again, the distribution of intravenous fluid depends on the solution's composition, both the osmolality and tonicity. Dextrose solutions generally distribute to all three compartments. Saline solutions distribute to the extracellular compartment. And then colloids remain in the intravascular compartment because of the oncotic pressure of the colloid. Let's look at a couple examples. The first example is a hypotonic fluid, half normal saline, or 0.45% saline. It's called this because it contains half of the amount of sodium and chloride as normal saline does. Think of the contents like a liter bag on the right, where half of the bag contains normal saline and the other half of the bag contains water. So the first 500 ml of the bag, which is sodium and water, goes into the plasma. Remember that sodium can cross capillary wall, but not the cell membrane. This means that all the sodium will stay in the extracellular fluid. And because water follows solute, it too stays in extracellular fluid. The concentration of each compartment hasn't changed. And so you're just adding volume to the extracellular fluid. Then the second 500 mils of the bag, which is just water, goes into the plasma because it doesn't contain any solute. The water follows our total body water distribution, where 2/3 of 500 mil, or 333 mils, goes into the intracellular fluid, and 1/3 of the 500 mil, or 167 mils, stays in the extracellular fluid. This expands both the intracellular fluid and the extracellular fluid. But the amount of water is not enough to change the overall concentration of these spaces. In summary, when you give someone a liter bag of half normal saline, approximately 667 mils will stay in the extracellular fluid, and 333 mils will go into the intracellular fluid. This type of distribution of water would be helpful if you want to expand the volume in the plasma. Let's look at what happens when you put an isotonic intravascular fluid into the plasma space. We'll start with D5W, which contains 5% dextrose, aka glucose, and water. So glucose and water go into the plasma space. Both of those molecules can easily pass the capillary wall and cell membrane. And because of this, they diffuse and distribute amongst the three compartments in a way that maintains normal concentrations in those compartments. In other words, they follow the same total body water distribution. This means that 2/3 of the glucose and water in a liter bag of D5W will go in the intracellular space. And 1/3 goes into the extracellular fluid. And that 1/3 in the extracellular fluid will distribute 75% in the interstitium and 25% in the plasma. Dextrose solutions are used to deliver water to the body. This would be helpful in the case of hypernatremia. It doesn't contain enough dextrose to lead to hyperglycemia. But dextrose solutions do not remain in the intravascular space. Therefore, they are generally not used for volume resuscitation. Now let's look at isotonic saline and lactated ringers. The osmolality of a liter bag is isotonic to plasma osmolality. So when you add it to the plasma, the overall concentration doesn't change. It just expands the extracellular fluid. And since the sodium can't freely move into the intracellular fluid, all the water in the bag stays within the sodium in the extracellular fluid. So an isotonic fluid will expand the extracellular fluid and not affect the intracellular fluid. This type of distribution would be helpful if a person has both a low serum sodium that you would want to bring up or increase and a low plasma volume that you want to expand or resuscitate. Finally, we'll consider hypertonic fluid. This liter bag of hypertonic saline, 3% sodium chloride, has a much higher osmolality than our plasma. When you add all the sodium in, it stays in the extracellular fluid, as does all the water in the bag. However, it increases the final concentration of the extracellular fluid because it contains so much sodium. Now the concentration in the extracellular fluid is higher than normal, and your body wants to correct that. It does so by pulling the water from the intracellular fluid into the extracellular fluid. So giving someone a hypertonic solution will not only expand their extracellular fluid with the fluid you give, but it will also shrink the body's cells by drawing water from the cells into the extracellular fluid. This can have clinical consequences if not monitored carefully. Therefore, we reserve hypertonic fluids for when a patient is extremely hyponatremic. This table contains some common intravenous fluids that you may give someone with a sodium or water disorder. The fluids are listed based on their relative tonicity. Tonicity refers to the concentration comparison between the two fluids, which we also think of as osmolality. For intravenous fluids, their tonicity osmolality is relative to that of plasma osmolality, which we know normally is 280 to 295 millimoles per liter. The tonicity osmolality of intravenous fluid determines the amount of fluid which distributes in the body water compartments. The first fluid in the table is hypotonic, meaning that the osmolality is much lower than the plasma osmolality. The product is half normal saline or 0.45% saline, which is also called half normal saline. The next three fluids are isotonic, meaning that their solute concentrations are the same or similar to plasma. Notice that the osmolalities may be slightly out of range of plasma, but they're close enough so that the body views them as isotonic. The most common isotonic intravenous fluid that we use in practice is 0.9% sodium chloride, which is called normal saline. The last fluid that we're going to talk about is the hypertonic saline, or 3% sodium chloride. And you'll notice that the osmolality is much higher than plasma. The sodium content of each fluid and relative tonicity osmolality dictates how the fluid is distributed in the extracellular fluid and the intracellular fluid, as shown in the table. We've now covered water balance and disorders. The main takeaways are 60% of our total body weight is water weight. Water is found in two compartments in our body, either within all the cells in our body or in the interstitial and blood vessel spaces outside of our cells. Water movement through these spaces is driven by effective osmoles. The main effective osmole that controls water movement is sodium. Therefore, water follows solute. When intravenous fluids are given, their distribution into the total body water compartments depends on the solutes in the solution and the osmolality of the solution relative to plasma. Thank you.